this is me quickly summarizing Rh negative pregnancy. So in pathophysiology, Rh negative pregnancy is only effective if the first child, or rather if the mother is Rh negative and the fetus is Rh positive. That is the first prerequisite. And for the fetus to be Rh positive, the father has to be Rh positive. That will yield a 50% chance for the fetus to either be Rh positive or Rh negative. So what happens is, and pathophysiology in fetal circulation that is Rh positive, during delivery there is feto-maternal hemorrhage that occurs. As a result, from the some of the fetal blood escapes into the maternal circulation. That causes exposure of Rh antigen that enters into the maternal circulation. This Rh antigen causes and activates the maternal immune system that forms antibodies against this Rh antigen. The antibodies are of two types, IgM and IgG. IgM are produced initially, and IgM, since they are larger in size, they cannot cross the placenta. And IgG can cross the placenta provided that they are produced in a huge amount. But IgG are formed slowly, so generally the first pregnancy escapes and there is no problem with it. But in subsequent pregnancy, there is already exposure and development of these IgG antibodies. So when there is a repeat exposure of Rh antigen, there is abrupt maternal immune dysregulation that causes formation of more IgG antibodies that are formed quickly and are produced in significant amount that cross the placenta into the fetus and cause hemolysis. So now let's see about the various complications that can occur due to the Rh negative pregnancy. So as I told that the main hallmark of this pregnancy is hemolysis. So the hemolysis occurs in the fetus is the main hallmark, and fetal hemolysis basically means there will be fetal anemia. Due to the hemolysis there will be jaundice. Due to hemolysis there will be increased production, and the erythropoiesis generally occurs in the liver, spleen and the bone marrow in child. So there is hepatosplenomegaly, bone marrow hyperplasia, that causes increased number of erythrocytes and erythroblasts in the circulation that gives rise to the condition known as erythroblastosis fetalis. And then the placenta also increases in size to produce more blood to the fetus, leading to placentomegaly. This placentomegaly in turn gives rise to two maternal complications that causes PIH and polyhydramnios. Now I think I need to make you understand a very core topic, that anti-D. What is its use and why do we need to use this? So the main thing you need to do is that it is only used in an unsensitized mother. Easy way said, that a mother that is giving birth to his first or her first Rh positive child. Only in such mother I can use anti-D, right? Because how does anti-D work? Anti-D works if this is the maternal circulation, this is the fetal circulation. From the fetus, this antigen enters into maternal blood. So before this antigen can stimulate the immune system, my anti-D goes and destroys this. So there is no immune system activation. So this can only happen in the first pregnancy, where the immune system is not activated and does not have any memory or any IgG that is pre-made. So in subsequent pregnancies, or when she's sensitized already, anti-D is of no use. So as we have discussed, how to understand that whether the mother is sensitized or not, we do that by indirect Coombs test, in which if the mother is negative, that means she does not have antibodies against the Rh antigen, so we say she is unsensitized. And if she is unsensitized, we do a separate type of management. And if she's sensitized, we do separate type of management. But the sensitized mother never receives anti-D injection. Now, if the mother is unsensitized, the first thing we do is, in antepartum prophylaxis, we give 30 macrograms of immunoglobulin anti-D. That is often described by the patients as giving of an expensive injection. It is given antenatally. Timing is generally, the in ICT is done in the first antenatal visit and repeated at 28 weeks. So after giving the antepartum anti-D, then we generally deliver at 39 to 40 weeks, that is we deliver at term with vaginal delivery, and we do early cord clamping. These three are very important to remember. And post delivery, what we do is we give RH, we do direct Coombs test on newborn's blood after delivery, and if that also comes negative, that means the sensitization is still not there, and thus we give another 30 micrograms of anti-D to the mother as postpartum prophylaxis. And this postpartum prophylaxis is best given within 72 hours of the vaginal delivery, but still can be given up to 28 days. And it is given even if we do sterilization post giving birth to the child. Now, if I speak about the management in a sensitized pregnancy, that is means a baby or the mother who is giving birth to her second baby, first of all, the first step is checking the antibody titer. And if the antibody titer reaches the critical value, that is 1:16 dilution, so if it's more than 1:16 dilution, like 1:32 or something like that, then we say it's a significant sensitization or significant titer, and then we look for fetal anemia. If it is less than that, we just wait and repeat the tests and do fetal monitoring and deliver at term. That's it. And if there is fetal anemia, we have to screen for it, and we do it mostly by Doppler of the middle cerebral artery, in which the peak systolic velocity, if it is more than 1.5 MOM, we can say there is fetal anemia. Now, if there is fetal anemia, we have to confirm. First of all, it's a screening test. So, in order to confirm, we have to take out fetal blood and do hemoglobin analysis. That is done by chordocentesis. That is the only indication for chordocentesis now. And so, after chordocentesis, we estimate the hemoglobin level and the hematocrit. So, if the hemoglobin level is less than, less than -2 standard deviations, and the hematocrit is less than 30 degrees, it's less than -2 standard deviation hemoglobin and hematocrit is less than 30 degrees, it's severe anemia. So severe anemia at term we will deliver, or if it is less than 35 weeks, we will do intrauterine blood transfusions. And if it is mild anemia, then again we'll observe and repeat the tests and then deliver at term. And the only difference is in this type of management, there is no role of anti-D, A, and then there is vaginal delivery and delayed cord clamping. What's the time of delivery? It's generally done in 37 to 38 weeks. In the previous one, it was 39 to 40 weeks. Now, these are some other indications of using anti-D. It's just that ends it basically.